this you cannot take this exam with this result to apply anywhere else because it's just part of your application. So it is worldwide. In the past, you need to come to the UK to write the exam, but now you can go for any person view center in your country. If you don't have that center available, you could apply for home test. They will send you a link and will do the exam through your laptop. However, there are two settings for this exam. The first set in January, February, which is round one, and the other set is in September, which is round three. So how do they use this MSRA exam? They use it for shortlisting for most of the specialty. So if you score the cut score for that specific specialty, as you all know, you are shortlisted for the next step, which is the interview and evidence upload. Sometimes in two specialty like the GP and psychiatry, it's all about the MSRA. You don't need to do interview. You don't need any portfolio. It's just score dependent seat or offer in GP and psychiatry. So it's very important exam again. So it contains two parts. The PD, professional dilemma, which is the SJT. It is like 50 questions. You need to finish them in 95 minutes. And there were 8 pilots questions. So 8 of the questions are not contributing to your mark, but you don't know which is which. So you got to go through all the 50 questions. However, there are two type of questions. They are writing questions and best three best of 8. The other part of the MSRA is the clinical problem solving, which is the clinical questions. 97 questions in 75 minutes. Again, there are 11 pilots questions. They are not contributing to the marks. However, the exam is a GP based and is meant to be for the GP. Hence, the GP trainee is T2. I think they write an exam called AKT, which is typically like the MSRA, SJT part and clinical part. Then a lot of royal colleges adopt the type of exam in their application process, and it became very popular now. So there is like a little bit advantage for the UK experienced or UK graduates, since the SJT part of it is about the JMC guidance, the NHS bylaws, and the setting here. That's why it's a little bit more difficult for the people who are not working or not studying here. So what specialties need MSRA? There are so many. As you see, ACCS, anesthesia, broad-based training in Scotland, clinical radiology, which is the most important here, community sexual and reproductive health, and you can go through the list. And neurosurgery ST3 is recently added to the list as well. So, as we say, this exam constitutes two parts, clinical and SJT. Are they the same in a matter of preparation and study? The answer is definitely no, because if you want to ace the clinical part, you need to do more questions. You need to be fast. At the end of your study, you need to be very quick. Just read the question and know the answer and go for next. Because it's, as we just mentioned, it's integrated clinical part, more like USMLE Step 2 CK. So there are anything there like obstetric gynecology, ophthalmology, statistics, everything is there. So it's a broad-based clinical exam. So you need to have like a broad-based knowledge, and you need to have like a test of the exam. And on the other hand, if you want to ace the SJT, what would you do? So this is one of the most important slide in this presentation, because most of the people that I know, they are very good high achiever. They have very good clinical knowledge. So they treat the SJT part just like the clinical. So they study a lot, they study hard, they try to memorize things, which is unfortunately the incorrect way to score high in the SJT. In SJT, you don't need to do a lot of questions to memorize a lot. You need to analyze. What does that mean? You have question about, for example, apology. When should you apologize to the patient? You need to gather these questions that from the authenticated resources that we are talking about them later. So you have multiple questions about the apology or about patient safety or about patient autonomy, for example. So you need to know why in this question the answer was to offer an apology. On the other question, the answer was not to offer an apology. So you have to understand, because basically what you are doing is making your own curriculum. In the clinical part, there are like a scientists and doctors who made like RCTs, made trials, and they have the evidence, and you just need to follow that evidence, to memorize it, to know the guideline. But in SJT part, unfortunately, it is not the case. You need to make your own curriculum. You have to make your own role, unfortunately. So you got to analyze so many questions, so many data, to reach a point that, oh, I know when to offer apology. I know when to breach confidentiality. I know when to prioritize things over things. So this is not an easy process, because if you are just doing questions, memorizing them, going fast, you are going to be faced by complicated question in the exam, and then you think, oh, I'm memorizing this question. And this is what happened for most of the people. I think I did well in this question because I've gone through similar question in the past. I gave the same answer, but the concept was different. Why? Because they changed just one word. And we will see during the exam. We have quite a few examples here. We will see that. So it's a bit tricky exam. The SJT part needs a lot of analysis. Okay. So I'm saying SJT part is more difficult, harder than the clinical part. This is not a thing that I claim. Look at this slide. It's a very important slide. This is like the GP statistic, the banding of the exam, because we know the exam has a banding: band 1, band 2, band 3, band 4. Band 4 is the best. So the GP 2025, because GP usually had the most of biggest number of applicant applying for the GP. So they were like 15,000 applicant. So they got to give the better analysis and better data analysis, because you have 50,000 candidates. You can really analyze a good sample of the candidate. So they publish this. Look at the
Dr.
list.
Mahmoud, sorry. Can I ask you to put this in full screen because it's an important slide so then everyone can be able to see it better?
I'm not sure if I put a full screen it would show or not. Do you see it now? Can you
Is it
see
in
it?
full screen?
Yes.
Oh, we can't see the full
That's the thing.
screen.
Yeah, I don't know why, but it's a full screen now in my screen.
Oh, okay. That's fine. Don't worry about
Okay,
it then.
let me try again.
Try to F5.
I have tried the 5, yeah, but it shows like a full screen in my screen.
That's fine. Don't worry about it then.
Okay, I'm sorry for that. So
Don't be sorry.
if you look on the left part of the clinical problem solving test score meaning, you see, because we all know the passing score was 186. So you see band 1, which is unfortunately failure. You have band 1 upper and band 1 lower. 3% of the candidates scoring band 1 lower, which is less, below 170, and another 30% scoring between 185 and 171. Both of them are failing score, because the pass score was 186. So 6% of the candidates, they failed the clinical part. On the other hand, 10% of the candidates, they failed the SJT. 10%. This is like more like 80% increase in the failing rate, or difference in the failing rate between the SJT part and the clinical part. So let's focus on the left picture again, diagram. We have people who just passed between 186 up to 210, which is band 2 lower, 9%. On the other hand, we have 18%, exactly the double of the candidate. They've just passed the SJT part, they scored band 2 lower. Again, we go through. If we went to the bottom end of the figure for both side, we see the people that scored band 4 lower, which is 291 up to 310. On the clinical part, they are 9%, but on the SJT, they are just 4%, less than the half. So it's harder exam, more tricky, and it's tough. So I'm not just saying that. These are the statistics showing this. So how do they mark the SJT? Now we are talking about the SJT. Is it important to know? Yes. So what does it signify? What does it signify here? Because we are telling in this slide. Let's first know how do they score the SJT questions. So let's start with the ranking question, because we spoke about the SJT part. We have 2 types of question, ranking and 3 best of 8. So the ranking question, usually you have the stem and you have 5 options. Sometimes they are 4, but ideally they are 5 options. So every single option equals 4 marks. So if you got the question fully correct, you got 20 out of 20. So let's see the example here. The ideal answer, for example, if you can see this column, if the ideal answer, the order should be C, D, then E, B, A. This is the sequence of the correct answer. But unfortunately, you kept it B, D, A, C, E. How do they score you? Okay. So C should be first, then D second, then E, then B, then A. If you got every single answer in its correct place, you got 4 out of 4 in this answer. But let's see, I kept B as my first answer. How would they score me? If B was my correct answer, my first answer. So how do they score me in B? They would say, okay, B originally, ideally should be the 4th answer here, ranking 4, but you kept it 1. So it is 4, the maximum score, but you change the position in 3 placements. So 4 minus 3, you score just 1, because it meant to be 4th in the ideal answer, but you kept it 1. So from the 4th, you put it higher up by 3 placements. So you are losing through 3 marks. So 4 minus 3, you are scoring 1. Okay. So D, you kept it the second option, which was the correct order. It should be the second in ranking. You kept it the second, so you lost 0 because you didn't change it. You didn't displace it anywhere. So 4 minus 0, you score 4 out of 4. So what about A? A should be last, should be ranked last, but you kept it number 3. You kept it 3 in the ranking. So you will lose 2 marks. And instead of ranking 5th, you ranked A as 3, as the third option. So 4 minus 2. Why 2? Because the maximum score is 4, but you displaced it by 2 ranking. So 4 minus 2, you score 2 out of 4. What about C? C should be ranked number 1, but you ranked C as the 4th option. So you displaced C from the first ranking or order, you displaced it to the 4th. So you lost 3 marks, and vice versa. So, however, further you displace your answer from the original ideal answer, you lose 1 mark by that. So 20 marks per question, 4 for each option. Sometimes you have just 4 options, so the question would be marked as 16 out of 16. So the maximum score could be 20, could be 16. So what is the minimum score if you didn't leave the question blank? You just kept the haphazard answer. You have no time, you didn't read the stem, you just kept any answer, but it is not a blank. You will score 8 minimum. You cannot score less than 8. 8 out of 20. Why am I emphasizing that? I'm saying the worst thing you could do to yourself to leave the question blank, because you will score 0. But if you kept anything haphazardly with no clue, you will score 8 out of 20. It is very low score, but it is better than 0. So blank question will score 0 if you have no time to reach that question. If you just kept anything, you will score 8 out of 20 minimum. Okay. So hence, you need to be quick, confident. You have to have the concept very solid in your mind. Whenever you read the question, you screen the question, you know that what is the concept are we talking about in this question? So you keep your answer. But if you kept thinking and working your brain hard and trying to memorize, you will lose some time. At the end of the exam, believe me, you will leave like 3-4 questions. And I believe this happened to all of you. 3-4 questions unanswered, and you will score 0 in any single question of them, which is a big, huge loss. So, because you might say, okay, I have 50 questions and it is like 90 minutes. I have enough time. No, it's not enough. The exam is very tough and the stem is very long and you have 5 options to read. So you need to be very quick. So read the bottom line, please. If you kept the upper and lower correct, you are scoring 16 minimum, 16 out of 20, which is a very fair score. What do I mean by that? Okay, let's say in that example, the ideal answer should be C, D, E, B, A. Somehow I managed to keep C in its place and A in its place. I knew from the concept C is the best and A is the worst, but I don't know which is which in the middle. No matter whatsoever, even if you jumble them up, you will score 16 minimum. Minimum 16 out of 20. How come? Because C is granting you with 4 marks and A 4 marks as well. This is 8. And D, E, B, if you jumble them up, you will just lose 4 marks because you cannot displace it so much because you already secured the bottom and the upper. So if you, for example, had no clue about the concept and by mistake you kept the first answer, the ideal first answer, kept it at the end, and you switched the last one, kept it at the top, you are losing 8 marks because the top one C, if you kept it here, you are losing 1 mark. If you kept it number 2, you are losing 2. If you kept it number 3, you are losing 3. If you kept it number 4, you are losing 4 marks. You are scoring 0. The only answer that you could score 0 within the first and last answers. If you have 5, the ideal answer, the first one, should be ranked first, and the last one should be ranked last. If you switch them, you score 0 here and 0 here. So it's very risky. Sometimes it's safe, if the question is very difficult, to keep the best answer on top, to find out what is the best answer, and to find out what is the worst answer, and to keep it at the bottom. And if there is no time, just keep anything. You will score 16 out of 20. It is not the best practice, but you need to know that. You need to know how to score in a smart way with a less effort. You might need that at the end of your exam because you are running out of time. We are coming to that. So how do they score the 3 best of 8? They will give you STEM and 8 answers, and you are asked to pick the best 3 of them. If you pick the 3 correctly, you are scoring 12 because, as we mentioned, every single answer constitutes for 4 marks. But if you pick 2 and missed 1, you are scoring 8. So you could lose marks easier here in this question. Yes, I understand the 3 best of 5 question looks easier, less tough than the ranking. Yes, I understand that, but it's easier to lose marks here because if you lost one answer, you missed one answer, that's 4 marks. If you lost 2, that's 8 marks. And you could lose the 3 altogether because you have 8 options. So losing marks is easier here. Okay, so why UKRC thinking about, Masterclass is helpful? Because personally, I've seen that document the UKRC are keeping, which is very helpful, about the radiology applicant that got offer. And thank you guys for filling that form. It's a Google Sheet. You put your MSRA score, then you put your portfolio, and you put your interview score. So that document, when I've looked into that document this year and the year before, I've noticed something. The cut score for radiology last year it was 555, which is very, very high. This year, the cut score for shortlisting was 544, which is 11 marks below last year, which is unusual because usually what happens is the competition is going crazy and the cut score is going higher up every year. But what happened this year, the exam, the SJT part was very, very tough. And the average score for all candidates was less than last year. Even the people, they worked harder. They studied SJT more, but the exam was very tricky. So the average was less. So the cut score was 544. So I've looked into that document and I've seen doctors scoring for 544, 545, which is the bottom score in the MSRA cut score for the shortlisting. And thankfully, MSRA is not contributing toward your final score this year. However, those doctors, you can look at that document still there. They scored very high in the portfolio and very high in the interview as well. So I thought we really have a very good high achieving candidate who have very high potential and they are very good at time management and very dedicated to radiology. They've done so many tester weeks, so many conferences, maybe master and PhDs. They scored very high in the portfolio, which is very very hard job to do to score high in the portfolio, because the portfolio is really radiology tailored. It's just about radiology. Everything should be toward the radiology. And they scored 40, 38, which is very high score. And on the interview, on the other hand, they scored 50, 52, 53. So they are really good doctors and they are achiever. But the problem is they had a bad luck with the SJT and they didn't study SJT in the past. And so why not to help these people, these applicants, to push them with the SJT so they can prove themselves, they can achieve themselves, because they are really good doctors. And they prove that portfolio wise and interview wise. And these are hard jobs. It's not easy to score high in interview and not easy to score high in the portfolio. So hence the idea came from. So why class? Why is not just like study group? You can study all together like a peer study group, because this will imply in your commitment. When you have a class and you are like, let's say time bounded, you have to be by this time attending the class. This really helps with the commitment. And the idea for now to do one session, of course, it will be free every month, and we might increase that, but maybe not now. But we need to keep at least one session per month. It's not to spoon feed the applicant. No, it's just to guide them, because because they are high achiever, they score high in the clinical part, but they need to approach the SAT part differently. That's it. So how do we do that? We are using authenticated resources like the SGMC guidance. They are more than 20 documents, the GMC guideline and other sub documents for example, for patient autonomy, for patient confidentiality, for social media. So there are 20 documents in total, and FPs, which is foundation paper. We have 4 foundation paper. They are the core of your study. You need to master these foundation paper in a, in a very detailed analytical way, and we are coming to that. So the second point here, you need to study the SJT in analytical view. You don't need to memorize or to go through quickly or to rush. If you rush through question, believe me, you find similar question in the exam and you will answer it incorrectly because you didn't absorb the deep learning point. So what does that mean? In every single question, we have concept, which is patient autonomy, patient confidentiality, patient safety. We all know that. On the other hand, to answer that question, you need to have deep learning skills, which are honestly difficult to acquire. So why in this patient safety question I've managed to score 20, but other patient safety question I scored just 8. Why? Because there were deep learning skills that I've missed, and we are going to learn them together through these sessions. So here there is no spoon feeding. You need to make the concepts yourself. Oh, from this question, oh, the concept was that, and the skills was that. So if you do that, you will never forget them again, and you will never need to memorize. So the approach is no memorization approach at all. It's about deep learning. Okay, so the classes should be 2 to 3 hours. The aim is to ace the SJT, and it's open for everyone. So in these sessions, don't expect clinical questions. We are purely talking about the SJT. However, if you have like question about the resources and things about the clinical, we are happy to answer them maybe at the end of the session. So don't expect recalls from the exam. This is unprofessional and illegal as well. So let's start with some examples. We are aiming not to lose any weight. We want to discuss as many questions as I prepared to be like productive in this session. So please, we don't need to waste time waiting who is reading the question. If you can volunteer, one of you reading question 1, the other doctor could read question 2. That will save us a lot of time. My experience before, when we have session like that, we waste a lot of time waiting for people to volunteer to read questions. So we are not judging anyone. It's not an exam. We are discussing the process of thoughts. That's it. And we are all learning from that. So who would volunteer to read question 1, please? Anyone? So I will ask haphazardly for someone to read the question. I'm sorry, but no one is volunteering.
I can read.
Yeah, please, please.
You have been working in acute admission unit for the past 4 months, and the patient has been admitted for severe abdominal pain. This is the third time that the patient has been admitted for the same condition, and you have conducted all of your previous assessment. You go to assess her, and when you see her, she says, "No, I don't want you as my doctor again. You cannot find out what's wrong with me. Please go and get me an experienced doctor."
No.
A, tell the patient that you cannot help her if she speaks to you in that way. B, reassure the patient that you will try your best to find out the cause of her pain. C, tell the patient that while she may be able to see a senior doctor if available, she may need to wait for a while to be seen. D, remind the patient that it's not your fault that she is in pain. E, offer to look for a senior doctor who is available to assist the patient instead.
Okay, doctor. So you volunteered to read the question. Thank you for that. Reading the stem, just the stem. What comes to your mind? What concept are we talking about here?
The patient is angry. How to deal with an angry patient?
So the concept is patient communication or dealing with angry patient. Fantastic. This is one concept. Is there any other concept here?
Patient autonomy.
Patient's right.
Patient autonomy.
Patient
Okay.
safety.
That's-
She doesn't want to see you,
Patient-
as a doctor.
You mentioned patient communication and dealing with angry patient. Dealing with the patient is the technicality, but the concept is patient communication. I like that. You mentioned patient autonomy. Very brilliant. What else do we have?
The patient's right.
Patient autonomy, which is patient autonomy.
Okay.
Patient safety.
Patient safety. Fantastic. Why do we say patient safety?
This patient came in pain and she didn't get up. She didn't recover from her pain. So it's your responsibility to treat the patients.
Okay, so we are talking about three concepts here. We have a patient safety issue, we have a patient autonomy issue, and we have a communication with the patient. Okay, so if I'm asking you, any volunteer, how would you classify these three concepts? Which one is like major, which one is minor? What would you think? Any answer?
The patient safety is
the
priority.
first priority.
Patient safety priority, okay. Well, patient
Then
autonomy.
after that, the patient autonomy.
Then
Um,
then the patient communication. So we are very concerned about how do we as a professional communicate with the patient, but unfortunately, we have better concepts, better concern. We have like more important concepts to deal with in this question. First of all, patient safety, and secondly, patient autonomy. So I'm just asking this question: is there really genuine patient safety issue here? What do you think, doctors? Because she came 3 times before, and there is nothing genuine. So why this question will come to in the real exam, and I would have less than 2 minutes to think to sort that out. Is that really patient safety issue? Any thought? Because she came 3 times in the past, and there was nothing genuine. Why is patient safety? We shouldn't just memorize things. We should understand why this is patient safety.
Because
it might be there is a new complaint.
What's that?
Severe abdominal pain.
So she came with severe abdominal pain in the past, but that doesn't qualify her to be like a patient safety issue.
It might be this pain is different than before.
We should not assume. We should not assume that it is like before. Every
Okay,
time
we
we have
shouldn't
to
assume.
see.
Okay. So is there any hint in the question telling me this is something could be new? I need the answer.
No, there is none because the patient did not allow to examine, so we don't have the new findings.
So I don't agree about that. There is a clear hint, not clear, there is a hint in the questions telling you, please go and see that patient. Who would pick that?
Severe abdominal.
No,
Yes, severe abdominal
no,
pain.
doesn't have. It could be severe, but it could be like somatic disorder or something that doesn't warrant anything. So just the fact it's severe, that doesn't mean this is something new, because he came with a severe abdominal pain in the past and it's clearly mentioned. So that doesn't warrant me to see her.
I think it's that you have conducted all of her previous assessments and nothing new is there. You
So,
need to do new assessments to figure out what's going on.
but if we are doing, and I believe most of you came through that question, when you see a patient 3-4 times and there was nothing, you're just trying to address the stress about the patient. You don't treat the physical symptoms because there was nothing. So I would say again, no one so far picked the hint.
As far as I believe, there is a possibility you might have missed something.
Okay, what is the hint in the question? Because this question is written carefully, very carefully, let's say, and it's telling you
Because this patient is acute admission unit.
Yeah.
exactly,
He was
exactly.
admitted before.
That is the hint that I want to hear. Sometimes you will see questions telling you you are on the ward and there is a patient that you know, and the patient is complaining from blah blah blah. Here, that will really like make the threshold for you to see the patient acutely very very high. So you are not rushing to see the patient because you know him or you know her already. You know the notes. You are seeing the patient every day. So the first hint in this question, hence I'm saying SJT is all about analysis. You don't rush through the question. You have to analyze every single sentence. He is telling you here, he is coming through the AEU. Everyone who work in the UK will understand what is AEU. If you didn't work in the NHS, AEU means AEU basically is the gateway between the GP, the A&E, and the admission. So it's something in the middle. What I'm trying to say, AEU is more like A&E, so the patient is acutely coming. So, as you all mentioned, I've seen that patient 3 times in the past, but he is coming through the AEU. That means this patient need to be cleared from the beginning because she is coming acutely from outside. She was not at the hospital, so I don't know about her history, has recent history. I don't know because he came through the A&E. So these kind of question would be of 2 types. Either they will tell you AEU, A&E, GP out of hour. That means the presentation is acute, something possibly new, potentially new. You have to see that patient. This is a patient safety issue. This is number 1. The other setting, he will tell you, okay, you know the patient. The patient is coming. The patient is complaining while she or he was at the ward. Oh, this is a different setting. You don't want to rush. You need to be smart, unless it's clearly new symptoms. But I'm just speaking about the very fast hint that you got here. The very first hint is the patient is coming through AEU, acute admission, which means this patient needs to be seen until proven otherwise. So I will start by seeing the patient because he came from AEU. This is the first hint. Hence, it's potentially patient safety issue. Why is patient autonomy? Because we understand the patient refused to see you. Okay. And patient communication because the patient is angry, upset. Okay. So this is the first hint. So it is a patient safety, and you need to see that patient so far. Okay. So when we are solving ranking questions, we need to have that mindset. Okay. I'm just picking up the major concept in the question. Then this is step number 1. Step number 2, I will challenge, I will test the 5 options against the major concept. Okay, so this question is very complicated. I have 3 concepts here: autonomy and communication. Which concept should I use to classify answers? What do you think?
Patient safety.
Yes, the major one. And this is a very, very nice trick. So now we are starting by scanning the question, understanding what is the concepts, what are the concepts in the question. Most likely in the exam, you will have a question that contains 3-4 concepts. It's never one concept straightforward, never. So I have so many concepts in the questions. The examiner is testing me against one of them. So I make life easy for myself. I will start by picking up the major one. Then any answer that address the major concept, it is like upward. It's upper tier, upper ranking question, upper ranking answer. I will keep it in the upper side of my answer. Any answer that dismiss, that ignore, that compromise the major objective or the major concept, I will classify it as a lower one. Okay? So, who is volunteering to classify these 5 questions to upper and lower tier according to fulfilling, addressing the major concept?
Me?
Yeah, please.
Okay. Tell the patient that you cannot help her if she speak to you in that way. It's lower
Why is lower, doctor?
because يعني the main concern here is the patient safety and patient you didn't يعني
Exactly. So in A, you are actively dismissing, ignoring, compromising the patient safety. She came through the AEU. That means she need to be seen until proven otherwise. She need to be seen. And now you are dismissing that. You are missing that hint. You are missing that patient safety by acting this way. So A should be classified as a lower answer in this question because this answer is not fulfilling, is not addressing the major objective of this question. I agree with that. A is lower. So what about B? What do you think?
reassure the patient that you will try your best to find out the cause of her pain. It's upper.
Why?
Because in this one you will address the patient safety by you will examine the patient
Okay,
and
fantastic.
you will try to find the cause of her pain.
Okay.
The other thing that the patient is it's not mentioned that directly she's upset, but from the scenarios look like she's worried. So we
Yes.
need to reassure her first, then after with reassurance, you will try
Okay.
to find
Okay.
the cause of the pain.
I would say this is a very nice double answer. I didn't ask about that, but you answered like a foreseen question. Okay, that's acceptable because this would be like the question number 3, but you answered already. So let's stick to our our process. Now we are scanning the question. We know what are we examined against. Now we are being tested against patient safety. So A lower, I agree with that. B upper again, and you gave a very detailed answer. I like that. So what about C? Is it upper or lower?
She tells the patient that while she might be able to seen by a senior doctor if available, she might need to wait a while to be seen. It's upper.
Why?
Because the patient will be seen and the cause of the pain will be found by the other doctor.
Okay. Okay. We cannot promise it will be found, but she will be seen at least.
Yeah.
So C is addressing the patient safety. Now we are not talking about which is the best, but we are talking, are we having like upper tier answers and lower tier? Yes. A is upper. Sorry. A lower. I'm sorry. B upper. C upper. What about D?
It's lower. Remind the patient that it's not your fault that she is in pain.
So
It's
I'm
lower.
asking here, you say this lower, but our classification for upper tier questions and lower is not about the communication. I understand in D the communication is very poor, but you didn't compromise the patient safety. Why do you say D is lower?
Because it's not mentioned that you will examine the patient or you will find any other one
Okay.
to examine her.
Okay. Please write down these hints. The first sense, you need to know where is the patient. Where is the patient coming from? AAU. That means this is new patient. You need to clear the patient from the beginning because came through acute pathway. This is the first hint. The second hint she just mentioned in D, option D, although there was no mention that you are not seeing the patient, but in SJT, I think one of the doctors mentioned something like that maybe 5 minutes ago. It's clearly mentioned, remind the patient that it is not your fault, that she is in pain, then full stop. So there was no any mention about seeing the patient, examining the patient. That means in D, you will remind her and then you will do nothing. And this is the first big hint in the SJT. This will help you in every single question. That is not to assume. If the sentence ends there, you need to treat that answer as blah, 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 and do nothing else. So you will understand how risky is the answer. In D, you will remind her and then you will do nothing. How can I say that? Because the answer said that. Full stop means you are doing nothing after that. So in D, you are not looking for the patient. You remind her, you communicate, but there was no clinical care here. So D is passively or inactively compromising the patient safety again, as she mentioned, because there was no mention about any clinical care here. I like that. So A lower and D lower, B and C upper. What about E?
E upper.
Why?
To look the you will try to find another doctor to senior doctor to examine the
Okay.
patient, so you
Fantastic.
can maintain the patient safety.
So please focus on that. Now, just a quick scan about the question. We knew there is a patient safety issue. Why I'm saying that? Because he came through AEU. It's not just resource management or autonomy. It is a real patient safety. This pain could be ectopic pregnancy. Who knows? This pain could be just IBS. Who knows? Because he came through AEU, that means this is an acute presentation or acute pathway. You need to take care of that. Again, this is a patient safety issue, potential patient safety. Any answer that dismiss that objective, it will go lower directly. So we have now A and D, they are lower tier answer. B, C, and E upper. You are just scanning the question, scanning the answer, and you have upper and lower. If you do that, you are safely scoring 16 out of 20 and doing very minimal effort, very minimal, but you are organized. How come? Because A and D lower, even if you flip them, you don't know which is which, you are losing just 2 marks. And the top tier, if you flip them over, you will score in total 16 out of 20. And in this exam, I'm sorry to say that, you have to be score minded. So you have to know how to score high doing the least effort. So again, scan the question, know what is the major concept here. Okay, the concept is patient safety. Which one of the answers are going with the patient safety? Blah, blah, blah. Which answers are going against? Keep them lower. So step 1, recognize the concepts. Step 2, reclassify the answers, upper and lower. Okay. So what is step 3? You don't need to memorize that because we will practice a lot. It became like a subconscious. And this is the idea about this. Hence, this class is not a class. It's a master class. You need to master the SJT. So now we have upper tier and lower tier questions. I always keep telling people it's easier for you to sort out the lower tier question first, then go for the upper. It's less intellectual process. You don't need to work harder for that. So if anyone could volunteer to tell us, we agreed that A and D are both lower tier, but how would you classify them? Which one is number 4, which is number 5? Who would volunteer to do that?
I can do that.
Yeah, please go ahead.
I believe D is the worst one because we are ending it and we're not doing anything for the patient.
What about A?
A has to be above D. So
Why?
uh,
We are
you're
not challenging anyone, doctor. We are not embarrassing anyone. We're just
Yeah.
thinking about how do we think altogether.
Yeah, because I believe at least in A, you are giving some information to the patient that you cannot help her if she speaks to you that way. But in D, you are just saying that it's not your fault and you're not ready to do anything about it.
Okay, that might convince me, might not. Is there any thing that you could think why A or B could be, one of them could be better than the others? So I will give you a little bit help here. We say we have a major concept. The major concept is the big filter will filter the answers into upper tier and lower tier. Okay, that's fine, fair enough. Then we have 2 other concepts. We could use these other concepts in that question. Hence, the question is complicated. We can use them to reclassify, to further classify the other question. If I gave you that hint, how would you classify A and D according to the concepts that we already acquired in this question? So we have other concepts about patient autonomy, and the third concept or the third objective was the communication, how to address angry patient. So what do you think? Which is better addressing like an angry patient? Is it A or D?
I think these comes before A
Say it again. Sorry, the connection was bad. Say it again.
because A. Yes, I said. I think D
Okay,
becomes
why?
before A because A sounds like a confrontational tone, which could possibly escalate the problem further and make the patient lose his trust more than you already have lost it.
So when it comes to things like that, you need to think again. Okay, what concepts could make A and D better than each other? So the other trick that I'm saying now is when you come to reclassify the lower tier questions, you don't want to look for the best of them. Make life easier for yourself and ask yourself which one is worse, because we are already talking about very bad options. So make it easy for yourself and tell yourself which one is worse. Is it A worse or D? That will make it easy for you. I have an angry patient and the patient is in pain. Which is worse? To tell her that please calm down, I cannot talk to you if you speak to me this way, or to remind her this is not my fault. If you think this way, you say, okay, this is much, much worse. Why? For two reasons. In A, you kept a term for the patient to receive the care, which is against the GMC guidance of treating patient with dignity, partnership, respect. You are telling the patient, as long as you are rude to me or angry, I'm not treating you. Be quiet, then I will treat you. This is unfair. You cannot do that. Unprofessional. But you gave her some options, as the doctor mentioned, which is less than ideal, incorrect statement. In D, you are withdraw yourself from the care. You just communicate with her, telling her, okay, you are in pain. This is not my fault. And the GMC is saying you need to be sensitive and show empathy to the patient, because you, as a doctor, advocating about the patient, you cannot harm them this way and telling them, okay. Basically, in D, you are saying, I'm not sensitive. I don't care about you. The pain is not my fault. But in A, you say, I will care about you if you care about me. It means this way. Although we are saying again, there is no patient safety, and this is not the ideal, but it is less harmful than D. And it's very clear you are bargaining the patient, you are blackmailing the patient in A. But in D, there is no that's it. This is not your fault. Just so A is worse than D because of the sorry, A is better than D because of two reasons. There is like smaller chance of patient safety here if the patient calm down. This is number one. Number two, communication wise, you are putting terms for the patient. There is still way of care, but she needs to change her behavior. But in D, there is no way. That's it. So before going for the top tier answers, I want to ask a question here, because as we spoke earlier, we are not going through the SJT question like they are clinical question. For example, if you have Miller rash arthritis, this is SLE. That's it. Go for the question. No negotiation here. It is not the case in SJT. In one question, we could discuss 6, 7, 8 concepts and skills, plus other questions as well, similar. So let me ask a question here. A was lower tier because there is no patient safety. Same wise in D. Could you use A in any settings in the SJT? Because now the thing that will stick to our mind that A was lower, A was bad, and I cannot use A. So is that no matter whatsoever? Is that the case all the time? Or do you think otherwise? Any thoughts? This is a very tricky point.
It
Are we
depends.
always yeah.
It depends according to the situation.
Okay,
I
more
think it will make a difference, because sometimes if we are in the A&E
Okay.
and come patient and speaking loudly and causing harm or to the other patients, then in this situation, this would not be lower. I think that.
Okay, very good answer. So we are not allowed to treat patient otherwise than with dignity, respect, and sensitivity. But the very fine skill that is very difficult to acquire, you need a lot of practice to acquire, is what is the threshold? what is the point that I'm saying, okay, I'm stopping here. No more sensitive communication. This is very, very fine skill. You need to acquire that, because from my observation, the last exam was all about this. Will test you against patient safety and communication, but to what extent you will accept? It's a very tricky. So what we are saying here, it's not acceptable for you as a professional to treat patient this way unless it's justified. Justified, you have very few examples or situations when you are professionally expected to challenge the patient. First of all, if the patient was racist or speaking in a derogatory comments, if that was the case, you need to challenge the patient against that, because GMC, NHS, and humanity in general doesn't tolerate the behavior. That doesn't mean you are not treating the patient, but you have the right to challenge the patient. And this is very tricky. Still, your duty to advocate about the patient is there. The patient is still a patient, but you are not expected to accept racial comments or derogatory comments at all. You have to say that, because GMC and NHS is teaching us to verbalize that. Zero tolerance in that case. So what other examples do you think you could apply that challenging the patient directly, confronting the patient? You got to know these things, because if you saw them in the question in the exam, you didn't say, oh, we practiced one question in the masterclass, challenging the patient was lower tier, so I put this lower. No, you got to understand the setting. There is no memorization. Here we are deeply learning. You are not memorization. You are not memorizing anything. So we know you cannot challenge the patient. You cannot confront them like that. It's unprofessional unless, first of all, there was like derogatory or racial comments. What other situation you could use that confrontation or challenging the patient?
Verbal abuse.
Verbal abuse, very nice one. Yes, if the patient was at the point of abusing you or colleague physically or verbally, that's it. So may I ask you, doctor, why we could do that if the patient is verbally abusive? For me, for example, it doesn't make sense. He or she was verbally abusive. I still need to care about him. So why I'm allowed? In fact, I'm encouraged to challenge the patient. Why? We need to understand, not to learn, because that understanding could be tested in a very tricky way in the exam. So if you understand the reason behind that, the root cause, you will never miss it. So any volunteer, why we are
It's because
encouraged? Say it again.
this might affect the patient safety itself.
Exactly. The researchers and every guideline saying if the doctor felt unsafe and abusive, that will affect the care of the other patients. And we understand I can minimize the safety of one individual in expense of the public. So if one patient has a gun and he's a killer, I can disclose this information or breach his confidentiality and expense of the public safety. We all know that. So here, if the doctor went to a point she or he felt abused, there is no point of that doctor treating other patients, because he will be classified as unsafe practitioner. He is unsafe to practice. He is not in his status of mind to treat other patients. So that's why. So it's all about patient safety at the end. So unacceptable here, but sometimes you have exceptions. They are very narrow exceptions. We need to understand that these narrow exceptions will allow me to challenge the patient, to confront them if I'm abused, if there was any kind of abuse, or if there was like a racial comments, because if he's talking racially against me, I'm not safe. I'm not in my status to practice. So hence patient safety again. So A and D lower. D, there is no chance for patient care. A, there is like unfair uh, unfair like term. Again, A is lower and C and D is lower because the patient is angry. What is the concept that you want to apply when the patient is angry? What is the one word you want to do? Any answer?
De-escalate.
De-escalate. Brilliant. So in A, you are not de-escalating, you are escalating. But in D, you are terminating the relationship. Again, other question. So whenever I've been faced by angry patient, I need to de-escalate unless he became abusive. There is no escalation. I need to protect myself. Protecting myself is protecting my patient. So you got to know the threshold. You need to know the cut point. If he's still angry and whatever and upset, that's fine. I need to respect him. Unless he became abusive. There is no respect for that action. Okay. So in D, we say D is the worst answer because you are ending the relationship. You are de-empathizing with your patient. You are acting like you are not a doctor. So could we use D anywhere else? And D could be like middle grade or upper.
If the patient is accusing you of being the cause of the pain.
So if the patient say you are the cause of the pain, are you allowed to say I'm not the cause of the pain? Again, if the patient is saying that, what would you classify that, doctor? Is that like abuse, verbal abuse, or that just like angry patient is escalating, or would you say what would you classify that? Where would you put that in the threshold that we spoke about? Is it like abuse or just angry patient? What would you say?
Angry patient.
Still angry patient, so you still need to de-escalate. So now we have that threshold. We know the spectrum. If the patient is abusive, that's it. I don't accept that. But if he's angry, even if he's very angry, I still need to de-escalate because I'm the professional one. I'm the doctor. I'm the GMC guidance bound. If he is angry, I still want to de-escalate. This is my job. And you gotta like scale the feeling against the problem, against the pain. If someone, for example, one patient, wife or daughter died already, you got to give them a little bit of space to express their anger. Okay, no problem. But if it's just something very simple and he's very angry for no reason, okay, you cannot expect that. So there is like a threshold. So still he's accusing, that classify as escalation from the patient, angry patient. You still need to de-escalate. This is not enough. So are you aware about the question is for everyone? Any volunteer, where could we use to remind the patient that's not my fault? The answer is almost always this answer is incorrect. Almost always. Because in this answer you are ending your relationship. Is there any or are there any situation where you could end your relationship with the patient? The answer is yes. Any examples when you could end the relationship with the patient?
When the patient is young, like less than 12 years old.
No, because we treat pediatrics patient all the time.
I think when the
No,
patient
like
is
when the abuse, in case of abuse, I'm saying when the patient is pediatric, like
Pediatric and
less than
abuse, you
12 years.
still need to safeguard them and to treat them. This is not an indication to end the relationship.
When the patient tries to have emotional kind of relationship
Okay, that's a
partner
very
from
good example. That's a very good example. If the patient is crossing the boundary between a doctor and patient, because we know we are not treating friends, we are not treating ourselves, we keep our relationship with our patient in a place of trust. So we are doctors and they are patients, and we need to keep these boundaries. We treat them with respect, dignity, everything, but we are not crossing the border. If the patient crossed the border, you need to explain to them, I'm duty bound, I cannot do that. If they still insist, okay, you can end the relationship, but you need to do something before that. You need to make sure that they are taking the care they need from other source. You need to do that because again, you are advocating about the patient. So if the patient is actively, insistently crossing the boundaries between you and himself, so you might need to end this relationship, but you need to find other doctor who could take care of the patient. This is not the first initial step, of course, but if you did that down the line, this is something justified. Again, if you are ending your relationship with the patient, you are still expected to do that in a professional way. You cannot say, okay, this is not my fault. Still, this way of wording is unprofessional, unacceptable. So D is unacceptable all the way. So A, there is like a bargaining, blackmailing with the patient. D is the worst. Now we've been left with B, C, and E. Which one is first? When we are answering ranking question, we need to pick one answer that solves the problem all over, forever, altogether. What does that mean? We all know that these 5 options are not sequence. This, then this, then this is not working this way. You got to read the whole stem, then you pick one answer that it is your only answer. Then, if that answer is not there, what would your only answer be? It's just like that. So I will pick one answer, will answer the whole question. If that answer wasn't there, what would be my answer? And this answer or this answer or this answer. So they are not collaborating together like the 3 best of 5. We are coming to that. So now we have these 3 options. Which answer of these will solve that problem of the patient? Is it B or C or E? What do you think?
B.
B?
Yes, to reassure the patient.
E.
And
How come?
E.
So I'm sorry. I will start with the doctor who said E. Tell me, why do you think E is the best?
I think E is better than other options because patient is in first place asking for the other doctor. So you offer that yes, we are going to offer you a patient, and then you tell the patient that while the doctor is here, is it okay if I examine you and then reassure that I'll do my best.
Fantastic. So we have a patient safety issue here. We need the only answer that could address or satisfy this patient safety query or concept to solve that problem. So the patient has the capacity, because we assume every single patient has the capacity, and she chose and she has the autonomy to ask for another one. She asked for other doctor, and you are fulfilling that by offering to look for a senior doctor. So you, doctor, said E is the best. Can I ask you a question here? Again, we are not judging anyone. We are just discussing the thought process. So in E, you are just offering. Is that enough? She needs to be seen. This is a patient safety issue. How come you offer? Is that confident enough to be the best answer? Because in SJT is very tricky. You need to focus on the actual wording. In C, for example, you are telling the patient, this is like an information, factual, I'm doing that thing. But in E, you are just offering. So do you think that signify anything, or what do you think?
Yeah, so if we take word by word, then it doesn't fulfill the whole agenda or the whole concept that we need to see the patient as well.
Okay. So we are giving this a potentially patient safety issue because the patient is coming through the AEU. So this patient, no matter whatsoever, need to be seen. So C is more confident, more firm that someone would come and see the patient. But E is like, I will offer. I'm not sure about myself. I will just offer, which is not the best practice. This patient needs to be seen. If you say E better than C, that means you miss the hint of AEU. So this patient, there is no other option. She needs to be seen because there is a big uncertainty here. We don't know what is the case. So E is offer, but C almost the same, but more confident. So I'm asking again. In C, you say she may need to wait, and this is not the best. There is a delay here. Why C better than E? And there is a delay in C. I might have that question in my head in the exam. Any answer? Which is better, C or E? There is
So
something.
E is,
Yeah.
I'm sorry, E is saying that the doctor is available to assess the patient immediately. So I think rather than waiting, he goes
So E is
first.
better than C.
Yes, because doctor is available, right?
Okay,
It says
fantastic.
that
So
offer to look for a senior doctor who is
is available.
available.
Fantastic. So in E, there is like a pitfall or downfall that is just an offer. It's not confident enough from you as a doctor, but there is an advantage that is doctor who is available. Okay, so there is no delay. In C, C got an advantage of telling the patient you are more confident, you are looking for actively for a solution for her problem. But on the other hand, there is like a delay. She may need to wait. Okay, fair enough. So still C and E. So someone say. So anyone would like to comment on C and E?
I think C will be better because at least I'm honest that there might be some delay,
Okay. What
and
about
that might like change her mind of accepting me seeing her instead.
E? Okay. So what about E? Is it losing the honesty point here?
I I'm not sure of
No, no, no. We're
how
just
see it
thinking.
as
Yeah.
this is
So it's like something like delegating our task to a senior who is already like resources is already in a difficult situation. So might be overburdening the resources and the available time.
But it's written clearly, doctor, who is available. Senior doctor, who is available here?
Might be that the senior is busy with other patients, like emergency. You are not sure that
Okay,
anyone is ready now to examine the patient. So
fair enough. So now we are learning two like secret skills, secret points here. You need to focus on that. C and E looks similar, but in E it's just an offer, but the senior is available. Sorry, in E, I'm sorry. In C, you are telling the patient you are more firm, you are more confident, and this is your job. But there is a query delay. I'm not sure. Okay, so what is your role or position in the question? What do you think? Are you registrar or consultant? Why are you?
F2.
By default, in the exam, every single question you are F2. So, as a F2, you have a role, you have competency, and you have limitation. So, giving me saying that, what do you think? Is it C or E better?
Think C.
Yes,
I
because
still think E is better than C because the senior doctor is available and the patient is angry. So offering first would de-escalate the whole situation immediately. Even
okay,
like after that, once the this de-escalation is done, you can still offer like tell the patient that while the doctor is coming, like, is it okay if I do something for
fair
you?
enough. Would
So
you mind me asking you two questions, doctor? Just to to explore more about thinking. So in E,
yes,
it's offer. In C, you are telling the patient. So I'm F2. Just imagine me F2 because the difficulty here, most of us are not F2, are not actual F2, either SHOs or even higher or even registrars, something like that. So you need to put yourself down to F2 level. So imagine me F2. Would I be working within my competency if I'm saying, okay, she might be able to see a senior doctor if available? There was be there. So let me put the question otherwise. Who is the one in the A&E or AEU could allocate task freely and has the power and the job description to do that?
can you repeat the question? I didn't get it.
Who is in AEU or A&E or wherever have the power, the job description, and the sort of supervisory role to allocate tasks to people, to doctors? Who is the one? The consultant, isn't it?
Okay, yes.
And
Can
if not
registrar not
consultant,
do that?
and if not consultant, so as F2, do you think you are able to allocate tasks to other F2s or registrars? Do you have that experience and supervisory roles and that competency and GMC bound duty to allocate tasks to other F2s and other seniors? Do you have that ability?
No.
The answer is no,
No, I
but
don't
you
think so.
have the right to escalate to them, isn't it?
Yes.
And you are, look at this trick, you are an AAU. We are seeing patient based on their clinical urgency. So I'm F2 now, I'm in AAU. I went to my senior, I have abdominal pain patient. Do I expect him to come immediately to see that, or he would reprioritize this within the task that in his mind? The answer is he will reprioritize because he is the senior. He is looking from above, and he has maybe cardiac arrest patient because we're in AU. He has a patient with dropping blood pressure, for example. So I cannot demand them to come and see my patient unless it's top emergency, like for example cardiac arrest. Other than that, I cannot demand because I don't know what the senior have, and he will reprioritize. So I can ask for help, but I cannot demand them to come and see immediately. This is number one. So knowing that, I should make the patient aware that I have the power to ask for help, but I don't have the power to make them immediately come and see the patient. I don't have the power because the senior knows more. The senior has more cases. He's supervising other F2s other than me, and he will reclassify the cases and reprioritize them. So as an F2 working within your competency in C, you got to be confident. Tell her that she might be seen by the available doctor. Why? Because you will ask for that. You have the right to do that. You need to be very firm about that. Again, other like positive point in C, you work within your competency and you told her there might be delay because you understand that you don't have the power to make them and come see her now. The only one who could do that, the consultant. He will ask, okay, you are ST5 registrar, please leave everything and go see that patient. That patient is critically ill. He is the only one. And legally, he is the only one responsible for the patient, for the ward. So you cannot go against the consultant because he is medico-legally responsible. Again, in this question, we have three concepts: patient autonomy, patient safety, and communication with angry patient. And the fourth concept that we are creating here is how could F2 works within his competency. So in E, okay, I will see other patient, but you are less confident. This is not your competency. Your competency is to be firm and confident that you will look for her, not offer. You tell. On the other hand, you need to do the patient some favor by telling her, okay, I will work within my competency. My competency telling me that I'm not sure that the senior will come immediately because I'm not the senior. They are the senior. I will ask, but the response will be reprioritized according to the clinical need. Why I'm saying that? Because we are in the AAU. Okay, so whenever they are telling A&E or AAU, that means we are seeing patient according to the clinical urgency, not the waiting time or the chronological presence. No. Again, C has 2 more points than E. You are more confident. You are working with your competency. You are actively, and you are stopping when your competency telling you to stop. When I'm saying stopping, I mean you are telling the patient that there might be a delay because your competency ends here. So C is better than E for these two reasons. But let's come to B. We are agreeing that we need to pick up one answer that will solve the problem. Would B solve the problem by any chance?
To reassure the patient, but it will not make what the patient has asked to be seen by another doctor.
So in B, I gave you the hint already. We are F2. So what is the role of F2 in AAU? Your role is to be like a frontliner. You need to see every single patient initially, clerk them, do the initial assessment, and then ask the senior. So in B, you reassure the patient, and this is within your competency. You need to reassure her. And you told her that you are telling her that I'm trying to find out. And this is your, let's say, job description. You as F2, you need to start with that. If you are immediately escalating every single patient to the senior will act like an F2 and they wouldn't appreciate that. So B is the best answer because first of all, you reassure the patient because we spoke about concepts. One of them is how to de-escalate, how to communicate with angry patients. So reassurance is addressing that. Actually, the only answer that actively addressing that. Number two, we understand the patient is asking for someone else, not because she is a racist or she doesn't like me. No, because she thinks that I'm not competent enough. So reassurance here is factual because GMC is saying any patient from AEU, the initial assessment should be done by F2, which is ABCD approach, something like that. Even if it's complicated, you need to do that, then escalate to the senior. So B, doing your main job as F2. B is reassuring the patient. And this is the best utilization of your DMC bound job. You are as a F2, you are duty bound to see the patient initially. So B, understanding that and acting on that. So B is the best, then C, then E. Why B is the best? Because I work my job as an F2, and my F2 job is telling me that initially assess the patient, please, then escalate, no problem. But you need to do the A, B, C, D, E. You need to do the initial assessment. If you are asking the senior, by the way, he will tell you, okay, what was your assessment? What do you think? Have you taken any vitals? He will ask about that. So you need to do B first. So this question is complicated. There are 4 concepts. One of them we just made it up, which is working within your competency as F2. That will help you seeing, okay, B is the best. I'm actively working as an F2. C is the second best because I know my limits. E is less confident, but they are all addressing the patient safety with some delay. Then A and D. Any question, or should we go for the other question because we spend maybe 45 minutes in one question?
Is reassurance the best answer in most of the cases?
Because you need to act as an F1. You need to find out what is the cause before referring, before escalating.
Okay, thank you.
Okay, who is reading question 2, please? We need to be quicker.
I can read.
Yeah, please.
I'll go ahead.
Yeah, please.
Yeah, you're working in the psychiatry department as an FI2. Gemma is one of the patients in your department with dementia. One of the nurses, Laura, tells you that Gemma is always shouting. You can see Gemma is shouting as you pass by. All the nurses in the ward are busy. A, go and see Gemma yourself. B, offer help to the nurses who are very busy with the patients. C, follow Laura's advice as she knows the patient better. D, tell the nurse from a less busy ward to come and see Gemma.
Okay. So what is this question about? What do you think?
It's your role as a doctor in the ward, as a
Fantastic.
psychiatrist.
Fantastic. Okay. What else could you could tell us as a concept of your competency, your duty as F2? Okay, I agree with that. And there is an element of patient safety, isn't it?
Correct.
Because we don't know why she's shouting. We don't know. So there is a patient safety and your competence as F2. So what do you think of these 4 questions you will classify as upper tier and lower tier?
A is upper.
A is upper. Okay, fantastic.
B is lower.
B is lower. Why?
Because in a way I cannot work like doing their job. It would be like, I don't know.
I think D is lower.
I think C is lower.
So we
Because
are still in
the
B. We
patient
are still
safety
in
is
B.
compromised.
Some people saying B upper, some people say B lower. Who is thinking B is upper?
B is upper.
Why?
Because if they are busy, if you can go and see, if you have the time, you should address the issue because it's a patient safety issue.
So they are busy with other patients, but we don't know what they are busy with. Is it like a nurse job? Is it just like handover, for example? We don't know.
Correct.
So offering help is not directly addressing patient safety, but is doing some effort.
Correct.
Because as we mentioned, we have a threshold. If it was mentioned in the question that they are busy with clinical job, oh, this is a patient safety, but they are busy. You don't know maybe they are cleaning the sheet, maybe you don't know. So offering help to the nurses is like, I would say, middle grade, because you are not directly addressing patient safety, but you are helping with something that you don't know about. Okay. So what about C?
That's lower.
Okay, because you are ignoring.
Yeah.
Okay. So what about D?
D is lower.
Why?
Because you cannot call someone else from another ward and assign them a role which is not their primary duty.
Fantastic. When we say we cannot, is that like a recommendation or like a very clear statement in the GMC guidance? Because our guidance is GMC, or is it common sense? Because mistakes start to raise when we are starting to make assumptions. So, what do you think about D? Is it something
I
fixed?
think it's more common sense. Why is that?
Okay.
Yeah.
Okay, so would you like to change the statement a little bit? We
Uh,
cannot say you cannot unless GMC is saying
correct.
you cannot. GMC is not saying that, but let's say it's not the best utilization of resources.
It's correct.
Yeah, but you cannot say you cannot unless, for example, GMC is saying you cannot treat patient and do, for example, CT abdomen unless the patient is discussed, advised about the risk of the radiation. This something that you cannot do it unless it's top emergency, you understand? Because GMC is saying that, but we cannot say you cannot ask. But let's say it's not the best utilization of resources. Yes, but
Yes.
so the only upper answer that we got A, addressing the patient safety directly and immediately. I agree with that. So A is number one. This question is tricky. We have like your role and competency as F2. You have potential patient safety issue, and you have some communication or relationship with your colleague, with Gemma, with Laura, because Laura told you something.
It's the
So an
second
A,
option.
say it again.
I think that C is the second option.
Why?
Because you know that mostly nurses are spending much time with the patients and they know their usual behavior.
Very good answer. So A is better. We all agree
Yeah.
about that. So some people are saying C is lower, and some people saying okay, C is upper. C is upper or lower. We are challenging this C against the patient safety. So one question, one thinking would be about okay, Laura actually the nurse, and she knows Gemma. Why not to believe her? She is professional enough, and to follow her advice. Here, answering this concern will answer the whole question. The whole question is based on this. So my question is, would I rely on Laura judgment or not, and why?
No,
No, I don't think we will.
The one
yeah.
who is saying no, could you explain yourself why no? Because Laura knows Gemma, and she's clearly saying she's always shouting.
because
Well, it
And
says,
that
sorry.
And we know this is like a ward patient. It's not like AAU or something. Okay.
you need to examine him first and decide which
We know that we agreed A is the best. I'm mean, proactive. I'm working as an F2. We are not losing this skill. We knew as F2, we are frontliner. We need to address that. We understand that. Okay. So A first. We are talking about C. Would I rely on Laura or not?
No, we can't
No,
make assumption.
Why?
it's an
no.
assumption. Yeah.
We
Maybe
can't
there is
make
another reason
assumptions.
why she's shouting.
Yes.
Okay, so this argument will never end. I need someone to pick something from the stem, like a hint, telling you
Be-
not yes, do or not to rely on Laura judgment. What is that
It
thing?
says
because
that
it says
Laura.
one of the nurses.
Okay,
The
She's
patient have
not like
dementia.
a
so
senior
let's
nurse.
listen to one by one. One
Sorry.
saying one of the nurses. So how does that change anything?
So she's not like a senior nurse or well-experienced nurse, kind of.
So I just believe or rely on senior nurses. No.
No.
Okay. So that is not an I think I could differentiate my judgment through.
I think because the patient is having dementia, so I can at least some point believe her or follow her advice, maybe, as the patient is
Okay,
having dementia.
so just for the sake of the time, I don't like spoon feeding, but let's say it. Okay. So the question is made in chronological way. You have to understand that. Now I'm an F2 in psychiatry. Okay. So Gemma is one of the patients in your department. This is like a general statement. Okay. One of the nurses, Laura, tells you Gemma is always shouting. This is again general statement. Now you can see Gemma shouting. Do you understand what do I mean? So the shouting happens after the general statement. This is something new to this is something recent to the general statement. She is saying, okay, this lady is shouting, which is correct at that time, but now you can see Gemma is shouting. Shouting is continuous verb shouting now, but the general statement is she always shouting. What do I mean? I mean is generally you are in F2. Generally, You have a patient with the dementia. Generally, Laura is saying this patient is always shouting. She is not commenting about the actual current one. And this is a very tricky point. So she is just letting you know this lady is shouting. Okay, fair enough. She is shouting. But after that, the lady start to shout. So is that fair for you, for Laura, to take that generic comment on that shouting? As you are blaming her, or like you are assigning her general statement to something that she is not aware of. She is not commenting about the actual shouting. Maybe the shouting is different now, and she was talking about different shouting in the past. So you cannot take previous comments about something new. This is the trick here. So the answer would be you cannot rely on that general previous statement for something happened afterwards at all, because you don't know if that was the same nature. You don't know. So here in this question, you cannot rely on that because the action happened beyond or after that comment. So when she made the comments, she meant the shouting was happening before the time before the comment made. So it's not, you are not doing a favor for her. You are just blaming her for something that she doesn't mean. Okay, so A is the best. Saying that, let's rearrange our answers. A would be still the best. You are F2. You need to see that. So what do you think would be classified as upper regarding the patient safety and your competency as F2? B or C or D? What do you think?
C would be the lowest one.
C and what? C would be the lowest one. Yes, I agree with that because you relied on inappropriate reassurance because the reassurance was beforehand, before the actual presentation. So you cannot rely on that. This is a big mistake. So C is the only clear lower answer. So A, number one, C, number four. I agree with that because we understand this complaint is new, at least new to that comment, to that reassurance, at least. So A, top, and C, lower. You cannot rely on something in the past for something in the future at all. Like is likewise when you are prescribing some medication from previous discharge summary 6 months ago. You cannot do that because things are keep changing. So A, upper, C is the least one. I agree with that. And we knew the trick now. So what about B and D? What do you think?
The
Is
second
it
would
D
be
the
B
lower?
after A.
I think D
A,
would be the
B,
second option.
yeah,
So
the
I
B
need
would be
just
the
one
second option.
doctor to tell me B or C.
B,
Why B?
because first you do for yourself, then delegate, and plus on top of that,
Okay.
delegating
Can you
work
read B,
to
please?
offer help to the nurses who are very busy with the patients.
Okay. What does that mean?
So you're offering help.
Patient that are
For
dealing.
whom, doctor?
Other patients.
For the nurses. So basically, the role number one in SJT, please don't forget that. Read the sentence and put the full stop and say to yourself and do nothing else. Now in B, you are if oh now you have your own patient who is crying, dementic, and you have other patient that the nurses are busy with. You don't know if they are busy with clinical thing or just nursery thing. You don't know. But basically, what you are doing, you are dismissing your patient. You are offering help to the nurses who are busy with other patients and do nothing else. So you are basically dismissing the shouting dementia patient. What do you think about this, B?
Okay, so if it goes, but because it doesn't specify to which patient we are
No,
helping,
it is
so
specifying
that would be a
help the
confusion.
nurses who are very busy with patients. Patients are plural. We are not talking about your patient.
So in this statement B, is it not talking about our patient
What do you think?
Gemma
You tell me. What do you think?
rather than the other patients?
Because
Because the way I
because
understood,
the conversation is like this. You have your own patient concerned about,
uh,
and the nurse is telling you she is shouting, and the group of nurses are all the nurses is very clearly written at the end of the stem in the word are busy. So you are helping the patient, the nurses with their busy work. So in B, you are ignoring your patient
um,
and helping them. Would you go for that?
No, I will not.
Okay. So if I'm asking you which is worse, B or C, what do you think?
The C is
think
worse.
Why?
worse.
Why?
C is worse because it is neglecting altogether.
Yes, exactly. In C, you are following and do nothing. At least in B, you are helping the nurses. You are offering something. So B number 3, C number 4, and by default, D would be number 2.
D comes to the second. Yeah.
Why? Because this is not the best resource management. I understand that, but you have sick patient, potentially sick patient. Maybe she has like abdominal pain. Maybe she's screaming. This is something new. She has delirium. Who knows? Because the comments, the reassurance was beforehand, and this is something new. When you have something new, you treat it as like acute presentation. Here you go for A first, then D, because we are talking about patient safety. Hence, if you understand what is the major objective, what is the major concept of the question, you will never miss. I'm talking about patient safety. Sorry, this is a patient safety. This is a new complaint. I will go for A. If A wasn't there, I will go for B, for D, because this is a patient safety. I will, sorry, mismanage the resources, but I'm sacrificing the resources in terms of patient safety, in expense of patient safety. My first and foremost concern is patient safety. So A, then D, which is perfectly correct, then B, then C.
Also, doctor, I had a doubt. So you can ask for help from other wards as well.
Yes, agree. But it is not the best for the resources. If you have some
Right.
help in your ward, that is the priority. But nothing.
Hello. Hello.
I think it's stuck.
I think
But
his line
everyone
Hussein?
is
works in the UK will know as F2 you have rotation every 4 months. Basically, in the question, trying to tell you you are the most senior junior in the AAU because you spent 4 months in every single rotation and you are at your 4 month. So you are very senior F2 in that place. So you are confident to reassure. That's why B is correct because you got to see every single hint and to use it. Because this is SJT. You need to know the hints and to play that like this puzzle game. You are here for 4 months. That means you are confident enough to reassure. You are the most senior F2 here. So here the hints that we got, please write them down. First of all, the reassurance was beforehand, was previous in time to the complaint. If the complaint coming later on, that means it's a new complaint. You need to work on that. This is like a potential patient safety issue. Not just because she is junior nurse or something. No, because the statement was accurate at that time, not for the future, of course. Who would read this question? We are running late.
Excuse me, Dr.
Yes.
Qusay.
Yeah.
In the previous question, I put B before D because I thought offer help to the nurses. I mean, by going and see the patient because it is a nurse's duty to go and see what's happened with the patient if she's shouting.
Okay.
So
So
by offering help, I
may I
mean,
ask question here?
yeah,
Okay.
B, yeah.
I
Offering
understand.
help to the nurses, I mean, I go by myself to see the patient while she's shouting and try to sort it out.
Okay.
That's why I put B before D.
Okay.
exactly that's what I thought.
I
B
have
sounds very ambiguous.
I have two questions here.
It's
My
very
question,
clear
my
because
question is
patient is in plural. If you see, it says with the patients.
yes, I agree with you, doctor. It's very clear, but I want to address that in other way because it's very clear grammatic wise. We are not talking about my patient. We are talking about with the patients. It's very clear here. But okay, no problem. I have better way to explain that. For me, it's very clear. You are helping the nurses with their own patients, not your patient. And I believe this is clear. But let's make a easier way. Who is the responsible to see the patient for the first time if they are shouting?
The doctor themselves,
Yes, because
whoever has encountered, actually.
You are an F2. So
Hmm.
your role as F2, the NHS is paying you to see the patient first.
Hmm.
You have to advocate about the patient. This is number one. You have to advocate. You don't delegate that task to anyone else unless you are busy with other patients. But if you are not busy, and in the question that is not clearly telling you are busy, you are the one who should do that. If you are doing less, that you are doing less job. You are doing your duty in a less efficient manner. You are less efficient F2. You are frontliner. This is your role here, job description. So you cannot rely on the nurse. This is incorrect. Number two, who had the concern? Who is the one had the concern here? It's unfair for everyone to have the concern yourself and someone else acting on that concern. No. If you have the concern, you act on it. You cannot delegate that concern. This is another skill we will learn. So GMC is saying you have to feel safe, confident enough to raise any concern at any time. You cannot have the concern and say, okay, I have the concern, but the nurse will act on it. No, you are not excused to do that. This is your job. Unless you are busier with more sick patient, yes, we understand that. You have to prioritize. Otherwise, you need to act on your concern, especially when they are busy and you are not busy. The question is telling the nurses are busy. Why to bother them to see your patient while you have the concern and you are frontliner? No excuse to do that. However, we don't need to go that further because the statement is clearly talking about the other patients. But either way, you need to understand I'm frontliner. I'm not leaving my job to anyone else. I have the concern. I need to act on that concern. Any question?
If this option B would have had offer help to the nurse without S at the end, the plural, offer help to the nurse who are very busy with the patient, then what would be the option, the
The same
second
thing.
option?
Because we discussed.
Because the nurse, we are talking about the nurse. We are specifically talking about the nurse who is in charge of
No,
Gemma.
no one is
So
in charge
how
of
does
Gemma.
it make any
No one is
difference?
in charge of Gemma. Laura is not in charge of, you cannot assume that. Laura is giving you like a general statement and she is busy. Why? How did I know she is busy? Because all the nurses, she is one of the all. All of the nurses in the world are busy. So you cannot assume that Laura is in charge. No, she's not in charge. She's busy now. She gave
So
you a
it does
statement.
say, she knows everything. It does say over
Said
here
who?
that she knows about the patient better.
Now you are changing the statement. Is she in charge or knows of the patient? Because anyone could know anything, but she is not in charge. Because when we are saying in charge, that means this nurse is responsible about the care of that patient. You have not been giving that information in the statement, in the stem. Don't make it up. So again, Laura is clearly busy with other patients. We don't know how and why they are busy with, what they are busy with. As F2, this is your job to go to see the patient, especially when you have the concern yourself. You cannot delegate that.
Okay, clear. Thank you so much for that.
No worries, no worries. So who will read question 3? Please, we don't need to waste time waiting for somebody
Shall
to.
I go ahead?
Yeah, please, please. Okay, just 2 minutes, I'll be with you. Just please carry on.
You you're working on a pediatric ward and a nurse who works in a different department approaches you to ask about his 6-year-old niece who is a patient on your ward. He asks what is wrong with her and what treatment she is receiving. You're aware that the nurse is not the patient's legal guardian. You have a good relationship with the nurse, and you can see that he is clearly anxious about his niece. So this basically is talking about breaching the information. I think he's gone. Dr. Mahmood? Dr. Mahmood? Hi.
So, what concept do we have in this question?
So this is like breaching the information, breach of information.
Yes, we are talking about confidentiality.
Confidentiality.
Okay, we are talking about confidentiality. Is there any big concept in that question?
The second is like treating the patient who is near to like a family or friend. So that is also not allowed.
But you are not patient related to yourself. So this is not applicable here, isn't it? Okay, we are not judging. You are going the right way. First of all, there is a confidentiality issue. I really respect that. There is another issue, another concept.
Dealing with a colleague or colleague
Yes,
relationship.
yes, exactly. There is a colleague relationship. He is asking you for a favor for something. How would you deal with that? It might look unreasonable or reasonable, we don't know, but you need to have a way, professional way to address that. Okay, there is another like minor concept which is not directly addressed here. When we are asking for information or trying to approach information about our relative or friends or something like that, you are not involved in that. He is involved in that. So we have confidentiality issue and we have inter-colleague relationship. Okay, so doctor, we are sorry classifying the answers into upper and lower tier according to the major objective, the confidentiality. So which of these four answers addressing the confidentiality issue? What do you think?
A.
Oh, A. Okay, so A would be upper. I agree with that.
Upper, yeah.
Yeah. B.
C.
No, I'm going one by one. So A
B
is
is upper.
B.
B is
A.
Okay, you're
appropriate,
going by
but
first, second, third now.
Say it again. Just one answer, please.
What I'm asking, like, are you going in an order or you're asking the first and the last option?
No. I'm saying A is upper. What about B? Is it upper or
B
lower?
is upper.
Huh?
B is upper.
Upper. Why?
Because you are letting your colleague know that it is inappropriate for you to discuss the condition as a
Basically, you
doctor
are maintaining confidentiality.
and it's not because the nurse here is a relative and is not involved with the direct care of the patient. So you cannot breach the confidentiality of a patient without.
Again, this is perfect answer. In A, we are maintaining our patient confidentiality. In B, we are maintaining confidentiality still. So A and B are upper in terms of they are addressing the major objective of the question. Perfectly fine. Okay. What about C?
C is lower.
Why?
The last option.
Because indirectly you are giving an information that there is nothing to worry.
I need to stress out this point. Whenever someone asking you about something medically, you cannot say there is nothing to worry because like you are giving impression that okay, he is fine. You cannot give this impression. Even the impression you cannot give it because this is like, I understand it is very minimal minor breach of confidentiality, but still you are duty bound to prevent that from happening. So again, C is lower in in a way that there is like minimal breach of confidentiality by telling, oh, our patient is doing fine. You are not entitled to do that. Okay. So A and B upper, C is lower. What about D?
D should be middle grade.
Why?
Little bit dismissive.
But we
Because
are
Upper.
again, please, if you are taking one home message from this session, to be structured. Our structure is to pick the major objective and to assess the question, the answers, to challenge them against that question. That's it. So D, challenge D against the major objective. Is it maintaining the confidentiality or not?
Yes, it's
It is
maintained
Oh,
maintaining
it
the
is upper. It is
confidentiality.
upper.
It's upper, yeah.
Make life easy for yourself. A, B, D upper, and C lower. That's it. Okay.
Yeah.
Yeah.
So C is lower. I'm asking question here because we are not just solving one question. We are understanding, learning the concepts, learning the skills from the questions. In C, we say it is lower because there is like a minimal, like breach of confidentiality. Okay. So are
Or
we?
do you mean, doctor, it's false reassurance?
No, we didn't come to this yet. Now we're just talking about the major objective. What you are saying is perfectly correct, which is very nice pick. But let's go structurally. Now, C is breaching of confidentiality in a way. We are giving like a hint or clue about how our patient is doing. So, are we allowed to give like a general statement about the patient if someone asks ever, or it's
No,
always
there can be some conditions, but I
okay?
don't think we can tell them we
Like what?
even have that person under our care.
Like what? The answer is correct, by the way. So I'm trying to tell you this. This is again a very tricky point. GMC is saying you can assume, please mind this, you can assume that your patient would appreciate, would allow you to update his close relative about his general statement. So there are terms for that. You cannot do that openly. Let's say that again. If someone asks you about a patient, you cannot tell, there is one exception. If the one who is asking is close relative, family, this is number one. It couldn't be like friends or boss at work or insurance company. No. First of all, to apply this exception, the one who is asking should be one of the close family. This is number one. Number two, they should be asking about general statement, not like the medication and discharge summary. No, just general. How is he doing? Just general statement. So that would apply. Number one, close family. Number two, general statement about the well-being of the patient. Number three, the patient should never ever mention that he doesn't want anyone to know. If he mentioned that, that's it. Because why? Why if the patient mentioned that, we cannot even breach even the exception? Why?
Because we are
That's autonomy.
the patient.
Autonomy. Because autonomy is more important than confidentiality. We need to learn that. Confidentiality is very paramount, very big concept in SJT and JMC, but autonomy is more prior, higher than the confidentiality. So autonomy comes first, then confidentiality. So again, there is an exceptional situation when we could update someone about someone without even asking for permission. There are like things need to be fulfilled. First of all, they need to be close relative about general statement, and the patient has never ever mentioned something otherwise. We could assume as per GMC that we could update them. My question here, we say C is lower, but I can see from the stem it is close relative, and he is asking about the statement, the well-being of the patient. Why still I kept C as a lower, as against confidentiality? Why?
It's not the legal guardian.
That doesn't mean anything, because we knew how would we deal with these things. We didn't mention about the legal guardian. We mentioned that just close relative. GMC is saying that, and the patient has never mentioned anything else.
Because she's asking what treatment she's receiving, which is very specific.
Exactly. He is asking about details. We cannot give him details. If the question changed in a way that he's asking generally about the statement, we could still give this information, saying yes, he's doing fine. No, he's doing fine. So this is the first hint here. He's asking about details. No one is allowed to ask about details because we are human being, and the GMC is made by human, and they are understanding, appreciating. Close relative might need to know the general statement. Just tell them we are human, no problem. But if they are asking about details, no, this is beyond the level of humanity and things. They have interest in something else. So we are not fulfilling that. We are not entertaining that. This is the first reason that we are not classifying C as exceptional disclosure. We are not, because he's asking about details. There is other reason. One of the doctor mentioned already, keeping C as a lower option, because this is a false reassurance. How do we know that nothing to worry about? Was there any piece of information in the stem telling me the baby is doing fine? We don't know.
No, there is
So you
none.
cannot assume again. In SJT, if you want to score high, you should train yourself not to assume. Whenever you start to assume things, because we are doctors, we are assuming patient care and patient safety all the time. So if we start to keep yourself assuming things, you start to fail, basically. So C is incorrect for so many reasons. First of all, this is against patient confidentiality because he was asking about details. You cannot give him anything. So it's all or none. If someone is asking about details, you cannot give him anything because the terms has been unfulfilled. So you are either telling them he's fine or not telling them anything, nothing in the middle. So C is incorrect for that reason. Again, it's false reassurance. You cannot, as a doctor, as a professional, give false hopes or tell something that you don't know yourself. Could be a legal case against yourself if the patient deteriorates. So C is incorrect for that two major reasons: one professional and one other professional, confidentiality and things. So still we know that there is an exception, but that exception needs some terms to be fulfilled. So C is lower. I agree with that. So we have A, B, and D. Could anyone volunteer and tell us They are both upper. Which one would be the first answer? Which would be the second and third?
First should be A, remind the nurse that this
Nurse,
is
that this is
confidential.
confidential. Okay, so you are saying A should be the first question, the first answer. Why?
Because it directly addresses the issue of confidentiality. We are directly letting the nurse know that it's a confidential
May I
information.
give you a little bit help here?
Yes,
And it
please.
is polite.
In this question, again?
And it is polite. It's a polite
Polite,
reminder.
polite, yes, professional and polite. But I want to give a little bit help here. We mentioned clearly our approach is to screen the question, pick the major objective, and challenge the other question against the major objective. You will know upper and lower. But when it comes to further differentiation, this is not enough. You need to accompany the other minor objective, the other objective here. What was the objective here? Or the concept in that question, the other one? What was it?
A relationship with the colleague.
Relationship with a colleague, and there is like a secret word here.
Anxious.
What's that?
He's anxious.
I like this. I'm telling you a secret in the SJT. Please remind that. Whenever you see in the STEM there is patient or relative or colleague anxious or distressed or worried or upset, this is like a clear, simple gift from the examiner. Whenever this is being written in the question, he needs you to address that immediately. Please do that. You will get for the first answer, no matter whatsoever. Because we are all doctors and we are all colleagues, and we need to treat colleagues with respect, with support. It's clear that the nurse is really worried about his niece, and he's asking not to get any benefit or to cheat on things because he is really worried. He is relative. So I'm still duty bound to confidentiality. I'm not breaching confidentiality still. But if I could reassure him or give him like alternative option because he's anxious, this would be the best answer. Why? Because I'm maintaining confidentiality and addressing the colleague relationship because he's anxious. Again, if you so anxious, distressed, worried, just rush for the answer that verbally or practically addressing that anxiety. So again, doctor, you said A. Would you change your mind now and pick another option?
Yes.
What?
I think if we picked D to ask
Yeah,
him
D.
to speak
Why?
directly.
Because D is practically addressing his concern
Yeah.
in a professional way. You gave him like alternative option. Again, D could not be the best answer always for confidentiality questions, but we understand this is like an SJT. This is like a puzzle mind game. They gave you two variants. One of them is patient confidentiality, and the other one is colleague who is anxious. So I need to solve both. D is not breaching confidentiality. Okay, I'm safe with the major concept. But on top of that, I'm directing or redirecting my anxious colleague to alternative option that would alleviate, would ease his anxiety. And that's it. So almost always A would be the best because you are clearly explaining the concept. So you are making sure that such an request would never happen again because you solve the problem from the root. You explain the concept. But D, on top of that, is helping your anxious colleague. So as an examiner, I will give you 4 out of 4, not 3 out of 4. If you keep that in mind, if you kept A, oh, fair enough. You will just lose 1 mark. But if you are perfect enough to keep in your mind your colleague who is anxious, I will give you 4 out of 4. And this is the strategy in the SJT. And I believe maybe 90% of us will go for A because A is clearly explaining everything. But the fact that there is an element of colleague relationship and there is anxious colleague, I need to alleviate the anxiety. So D would be
So, excuse me, Dr. Kusai, would it be considered like if I'm telling him go to and speak to her parents? I mean, isn't it dismissive?
okay. That's good. That's a good question. When I've ever been, let's say, confronted or faced by by anxiety or any like sort of that feeling, anxious, distressed, worried, I could address that in, let's say, three ways. First of all, I can address that verbally by reassuring, by saying, please don't worry. No, no, please don't worry is not professional, but by saying, okay, I'm doing my best. So I can address that verbally. This is number one. Number two, I can address that practically by saying, okay, I see you are anxious, without saying, just doing. This is the solution, go for pulse. This is the thing, do that. So I'm addressing that anxiety practically. The third way, I could refuse, especially if it was like inappropriate request or something, but I can address that by explaining. So that to address that anxiety doesn't mean you always need to fulfill or entertain that request. No, you could address that by explaining the concept. So you already addressed that, or giving other alternative options.
Alternative.
Yes.
Okay.
So here in D, basically you are being more proactive, more helpful, and direct them toward the appropriate channel. Okay, so why in this question I chose to go to D? Because first of all, he was anxious. This is a clear hint. Number two, because he was the uncle. He is genuinely worried. He's not like the boss in the work or just normal strange friend or something like that. He is close relative. So his generation, the thing that generates his request or question is that the feeling that he loves or he care about his niece. So I need to address that. So there is a genuine relationship here or genuine link. So I need to address that. For example, if it wasn't the uncle, it was like, for example, any neighbor or something like that, I wouldn't go for D because I'm not, let's say, ethically bound to find solution for them. I'm just professionally bound to explain the concept. But because there is a genuine link and genuine anxiety and worry here because of the relationship. So D first, then A definitely. C would be the last, and we know that, and automatically B would be number three because B is like more confrontational, is more harsh. Why would I be harsh? While I could just remind him. So look at the actual wording, remind the nurse. That means you understand, he understand, but you need just to remind him. B, you are very confrontational and very harsh way. So D, A, B, C. Any question? What
Thank
have we
you.
learned here? You need to look for the cues. There is an exception for telling general statement about the patient, even without taking permission. There are terms for that. And we need to be systemic, go for the major objective to reclassify, then use the minor objective to see which is which. Who's reading number 4, please?
So, doctor, the answer
Yes.
D, A, B, C.
Say that again. Oh, yes. D, A, B, C. Yes.
So you mean B is harsh, is it?
Yeah.
Okay.
And for no reason. He was just.
So why we didn't put it the least if it is harsh?
No. See, again, it's confidentiality because we know we are following the major objective. We are not losing this skill. We are classifying upper and lower according to the major objective. Major objective is seeing C is lower. That's it. Then we classify. Okay, who's reading for, please?
Okay, thank you.
Welcome. Please,
I can read.
don't waste time. Yeah, please, go ahead.
Yasmin is on a medical team that's well staffed, so her consultant has asked her to help out another understaffed medical team for an afternoon. She has completed the jobs for her patients and would be happy to help another team if needed. However, the ward nurse in charge is very unhappy about losing a team member for the afternoon and asks her to stay on the ward but does not give her a reason.
Carry on.
A. Ask the ward nurse why she would like her to stay in the ward. B. Speak to the consultant about the nurse's request for her to stay on the ward. C. Report the nurse in charge to the clinical director. D. Stay on her current ward as the tasks she is given might be easier.
I think A is the best and C is the worst. No, yeah.
A and B are upper.
A and B are upper.
E and D are lower.
So this is not the way. The way is after scanning the question, what are the concepts or the values that we are talking about here? So would you like to tell us? What do you think?
One is the resources.
Resource is fantastic. Yes. What else?
Second is safety, because if there is
Let's say
less
safety.
resource,
There is no immediate safety. Let's say patient care. There is no
yeah,
immediate
yeah,
safety, but still
You
there is a
stop
patient care.
there. I think
yeah.
it's
Because
you.
if there is less resource in one ward, the
Yes.
safety is can be compromised. Not necessarily it will be, but can be.
Yes. So we have two concepts, as you mentioned. There is like a resources concept, and this word well staffed, the other word is understaffed. But this in itself is not a problem if there is no need. But
Colleague relationship.
this there is like a bit of, I like this one. I'm coming to that. There is a bit of patient care because everything is done in my ward, everything is done, but in that ward there is like still jobs, so there is a patient care. Maybe there is no immediate patient safety risk, but there is a patient care. These jobs needs to be done before 5 p.m. And there is like intercolleague relationship. Again, that's very nice. We have three concepts here. So the major one is the patient care. We need to deliver the best care to the patient in time. Hence, the consultant asked me to go that word. This is the whole point. So, in these four answer, which is upper, which is lower? What about A? Is it upper or lower?
A is
Upper.
upper.
Is it upper? Why?
You're trying to understand the reason why the nurse would want you to stay on the ward if she's not giving you a direct explanation of why she wants it.
I respect this answer, but is it addressing the patient care directly?
No, but yes, it may be, because if she is asking to stay, maybe something is coming, emergency. We don't know, so we cannot assume. So that's why
So let's say,
approaching the nurse.
maybe A is not addressing the patient care in that ward, but it might be addressing the patient care in my ward. Let's say, because now we have two wards in the scenarios. My ward, which is done with everything, and the other ward, which is still demanding. So A is not addressing anything in that ward at all. But let's say 50% addressing the issue in my, giving that she might give you a reason and she might not. So let's say 50% in my word and 0% in that word. In that word. So what about B?
B is upper.
Why? Sorry.
Because the consultant has requested you, but the consultant is not in the ward right now. So if the person in the ward is asking for something, it's better to discuss with the consultant.
But I think the consultant has given a job and it's already being done. So just some additional, it says would be happy to help another team if needed. So we have not reached to the point where it is needed anymore.
Okay.
I think because he is the one in charge of the team.
Okay. So it's again resources.
Yeah.
Okay. So in A, sorry, in A, okay, I'm addressing the concern of the nurse, and we know almost, let's say always, addressing the concern of the patient or the colleague or asking why would be the first step before going any further, because we cannot assume. So the nurse has some concern, had some concern. It's fair because she is senior nurse. It's fair for me to ask, and this will take maybe 5 minutes, less than that, to understand. So A, it's fair enough. I agree with that. B, speak to the consultant. We're not sure what this will gonna add. So let's keep it this way because a lot of hints coming afterwards. What about C? What do you think?
It's
Report to clinical director is the last option, because you don't want the whole thing has been done. Like the patient care is not being compromised. So escalating to that level is a big deal.
Okay, so I might ask you a question here. Now the consultant is telling me when you finish your job here, go for that ward because they are understaffed. Now the nurse in charge is stopping me. Can I report her for that?
First to a consultant, then to nursing in charge, then to the director of the hospital.
So the question is still, if someone is stopping me from going to other ward or doing some task
Mm.
asked by the consultant, can I report him or not?
Yeah, you can. You should actually.
So C is upper or lower?
But in this, the consultant request has already been completed.
No. The consultant has two requests. First of all, telling you finish your job here, which you've done. Then he asking you go for the other ward. You haven't fulfilled that yet.
No, I will not report.
Because before reporting, it's better to discuss it with the
Agree.
nurse and then the consultant, then report.
Again. Please, we all know report is the extreme end of the communication. In SJT, they have. I'm talking about escalation wise. I'm not talking about discussing my concern with my colleague directly. If I'm escalating, first of all, I can discuss with the senior, discuss the action, discuss the concept. This is number one. Number two, complain. Number three, report. So report is the far end of it. If you have a concern, you have to discuss with the colleague directly, then discuss with the senior, then complain to senior, then report. So report is the fourth step. Report is the end. Basically, in report, you are leaving everything. You feel like this colleague is very dangerous, risking the patient safety in a very harmful way. So I need to report himself, not report the action, report him to be reported to higher authority so he might be punished extremely. That what reports mean. So again, you have to discuss with him, then discuss with the senior, then complain to senior, then report. Report is the far end of the spectrum. So we understand we need to discuss with her in A before going anywhere. Report is very unfair, and you always need to keep the threshold skill in your head. Does the nurse in charge here reach the threshold of reporting? Because sometimes, what I'm trying to say, you can report without going to discuss, complain. You could go for reporting immediately. When can we do that? It's a very important skill to know when to use the extreme actions because they don't usually come. They come once in the exam and you will miss them because you don't usually use that skill. You don't usually report. When could we report immediately, or reporting would be higher up in the ranking? Any thought?
If
If
I
What?
tried
patient
another ways,
Say it again.
And there is a threat.
if she can affect patient safety.
Again, if there is a patient safety issue, it's better to discuss, isn't it?
If there is a patient safety clearly be compromised in the other staff, in the other ward, and she prevent that.
Okay, I might like modify the answer a little bit. I am entitled to report because reporting is not always bad thing. It's not always, and sometimes we will see maybe few coming sessions. When should we report? By nature, we solve a lot of questions. Report is almost always step number 4 or 5, but that doesn't mean report couldn't come as a first option. Okay, so report could be the first step because we understand we are not now memorizing anything. We understand reporting would be prioritized if there is an like major or immediate risk, plus you've already exhausted other solutions. For example, you are talking with one colleague and you've noticed that the colleague is not examining the patient, just writing imaginary findings. And you spoke with him and he's dismissing you. So you exhausted the initial solutions, and this is clearly written in the question. Number two, this is not the first time. Even if he is ignoring you for the first time, you don't report. But if it's a habit, that means this is not a mistake, this is like an attitude. So you need to report him. So again, you could report someone if there is like a genuine need, like patient safety, immediate patient safety, like an ethical issue, and he knows that is the wrong thing and he is not listening to you, not the first time. Another example, if someone is stealing, for example, patient watches, would you, and you are 100% sure he stole the watch, would you discuss with him? The answer is no, because
No.
first of all, this is a serious thing, need to be reported. Secondly, you can assume that you already exhausted the other solution, which is discussing with him stealing is unprofessional and illegal, because we all know stealing is illegal. So you don't need to speak with someone to tell him that stealing is illegal. You don't need to do that. So if someone is doing that, you can report him. So report is not always wrong. We need to know when to use the reporting. So report here is very lower because the threshold is not met yet. There is other word which is understaffed, just understaffed, and there is no explicit patient safety issue. So you cannot report for that. What would you say in your report? She prevented me from going for understaffed. So they will ask you, was there any genuine need? Any patient safety? You would say no. So why are you reporting? This is not the best way to communicate. So reporting is not for communication. Reporting when you use it, that means you are not communicating anymore. You are just going for the last resort because there was nothing left for you to do, unless it's something illegal like stealing, things like that, or something continue like persistent, and you exhausted other options. So report is not the best here because the threshold hasn't been met and still very, very early, and there is no genuine patient safety here. Let's say patient care, but not patient safety. So stay on her current ward as the tasks she is giving might be easier. What do you think about that?
Lower.
Lower, why?
I
Because
prioritize
it
my rest, and I don't care about the other understuffed.
Exactly. In D, I prioritize the communication with the nurse. I pleased her, but I missed the patient care because in that ward they are understaffed. They need some help. This is number one. Number two, we mentioned three concepts here: patient care, colleague relationship, and what was the third one? Resources. And I played against the resources because the resources telling me I need to be there with them. Okay, so in D, I missed the major concept, so D is lower. In C, is it upper or lower according to the major concept? We are talking just about the major concept. Is it upper or lower?
how do you mean by major concept? Like we are
The major
dealing
concept in
with
that
this.
question, we agreed upon the major concept, the major value in this question. We agreed upon that, which is patient care. So is C upper or lower according to that?
It will be better than D, of course.
So D is lower. So C is upper or lower? This is the question.
Lower.
Why
Lower.
lower? We need to be systemic. This way will never fail if we follow the best way. So we say D is against patient care because I'm prioritizing the communication. And it's clearly written the word they need me. C is lower, but why is lower? Because we had the skill, we learned the skill that in SJT you need not to assume. In C, you will report the nurse and you will do nothing else. How did I know that? Because they did full stop. After full stop means you are doing nothing else. So in D, you stay in your ward. You're in C, you are reporting the nurse and you will do nothing, which is again doing nothing for that ward. You've just been busy with reporting the nurse unfairly, let's say. So D and C, they are almost the same. You are doing nothing for that word. So they both lower. A and B, you are actively trying to address the issue before you are going to that word. So A and B upper and C and D lower. So we said step 3, go for the lower ones and decide which is worse. Make life easier for yourself. Which is worse, C or D? What do you think?
C.
Why?
Because it's just a clear statement and you're not doing anything about it. Report the nurse.
Exactly. In C, you are missing the patient care, you are missing the resources issue, and you are missing the communication with a colleague. But in D, at least you addressed one of them. So again, these questions like the mind game. You have to know the cues, play against them, and you will score. Now we have 3 concepts. One of them is major that will classify to upper and lower. C and D, if you are following not to assume skill, you will know C and D do mean do nothing. So C and D lower because you are not addressing the patient care in that word. In C and D, in both of them, you are not addressing the patient care. You are not addressing the resources issue. Both of them. But in C, on top of that, you are harming your relationship with your nurse in charge for no reason. If there was a reason, I will appreciate that. I will keep it up. But we learned how to report, when to report. Now you are doing that for no reason. This is extra negative point. So D is better than C because C is worse than D. Now, which is upper, A or B? What do you think?
I think that would
A
be
is
keep
better.
up and understand the situation. It will not take much time.
Okay, fantastic. So I will help you again. That means B is better, isn't it? So I will help you again. Now, the major concern or major value of that question is patient care. Okay? Who is in the hospital, in the medical team, who will know best about the patient care and resources allocation? Is it the consultant or the nurse in charge? Because
Consultant.
because sometimes the nurse in charge is better than the consultant in her job. Like what? Give me an example. Like infection control. She is the one will know the best. But we are talking about resource allocation, doctor allocation. We are not talking about nurses allocation. We are talking about doctor allocation. Who would know better? The consultant. Because we are not talking about nurse, about you, F2. So, in other words, who would do better in terms of patient care when it comes to allocate doctors? Consultant. But that doesn't mean I don't need to understand the concern of the nurse. Still, okay. Again, the question is giving you two very nice hints for you to go for B, not A. Who could pick them? At least one of them.
He does not give her a reason.
No. If he is not giving consent, you need to ask.
Yeah.
Maybe because it said if needed, to help another team if needed.
No. There is something
Because
in.
my jobs
She has
are
already completed her tasks for the afternoon.
Say it again.
She has already completed her jobs for the
Okay.
patients.
Yes.
So
Now,
there is no
I'm
reason for her to.
exactly. Now as a doctor. I'm in charge of my patient. Doing my job with my patient equals to patient safety and patient care. It's very clearly written in the STEM that the consultant asks you to help another understaffed team. Okay? That means the plan of management is formalized, has been formalized by the consultant. What does that mean? Please write this down. Whenever the consultant is asking for something, that equals guideline. Here in the SJT or GMC, consultant equals guideline, equals patient safety. They presume the consultant is always correct because this is the case until proven otherwise in the question. If the consultant is asking for X-ray, that means the patient safety is saying X-ray is important because he is the most responsible physician. So always consultant tasks or asks or consultant plans equals patient safety. Always until proven otherwise. Until when consultant asks for something, that means he is considering the guideline, he's considering the resources, he is acting in the best interest of the patient to the best of his knowledge, which is the best knowledge in the team. Write this down and act upon that. So consultant is telling you go for the afternoon, and you yourself has no problem with that because you could say no, I have other options, but you are happy with that. And the number two hint, the second most important hint, or the first most important hint, that you've already completed everything for your ward. So there is no patient care to be delivered extra. There is no extra care. That means the patient care in your ward is already delivered, fulfilled. But still, there is a patient care as per consultant request because we know consultant equals to guideline, equals to resource management, equals to the correct plan of management. We know that. So, in my word, everything has been done, nothing to be added at all. Why? Because the question is saying that. The STEM is clearly saying that. You cannot assume. If the STEM is saying that, you don't care about the. It's not you don't care, but But it's very hard for the nurses in charge to justify otherwise because it's very clearly written. So patient care is already done, fulfilled, but there is patient care, not patient safety, but patient care in the other word because the consultant asked for that. So now it became patient care, in other word, VS concern of the nurse in charge. So what would you go for? What would you go for the patient care, in other words, or would you prioritize your colleague concern? What would you prioritize?
I
Patient care.
think the patient care is more
Definitely,
important.
because this is very atypical question when the patient care is clearly mentioned, fulfilled, and we don't have so many questions when they are telling that clearly. This is very atypical. So we have a patient care already fulfilled in that question. So anything else would be like confidentiality, autonomy, resource management. The nurse might have genuine concern, but they would never be about the patient care because the patient care is backed by the consultant and the statement in the question. So patient care, nothing to do with that. But he might have concern about patient confidentiality, patient autonomy, whatever. But it's not patient care. Why I'm saying that? Because the statement, because the consultant. So she will have concern about something might be genuine, but it will never be a patient care. It will be something else. So whatever it was, patient care is first and foremost. So we learn patient confidentiality is very paramount, but autonomy is more important than confidentiality, and patient care is more important than anything else. So she might have a concern. This concern might range from just resource management and colleague relationship and just simple jobs up to patient care, but not in this question. In this question, we are not memorizing because it's almost always asked about concern would be the first answer, but we know why. Because the concern might carry patient safety and patient care issue, but not in this question because the patient care is already fulfilled and there is no room for extra discussion or concern. So I will go for patient safety. The one who asked me for patient safety, maybe I'm too junior to challenge the nurse in charge, so I will go for my consultant to confirm the patient care, which is B. Why we are choosing B? Because B is prioritizing patient care, in the other word, against my colleague concern. My colleague concern could be potentially patient safety, I don't know, but not in this question. That's why this question is very tricky. You start with B, then A, then D, then C. It's almost always you ask about patient or colleague or patient relative concern, unless, please write it down, it's playing against the patient care or the patient safety. Unless if it's clear step to maintain the care or the safety, you go for that first. Okay?
Sorry, what is the answer again, please,
The
doctor?
answer is B, definitely. Then A, because they are both upper, B, then A. Then in the lower answers, D, staying and doing no harm to the nurse in charge, better than staying and doing harm to the nurse in charge. B, A, C, B, A, D, C.